Good afternoon, everyone, and welcome to the 5th edition of the Zero Dose Learning Hub webinar series, brought to you by the Gavi-led Consortium of the African Field Epidemiology Network, AFANET, and the Africa Health Budget Network, AHDN. We're thrilled to have you here as we dive into today's theme for the 5th edition of the Zero Dose Learning Hub Nigeria webinar series, Breaking Barriers, Technology, Decentralization, and Partnerships to Close the Immunization Gap. This webinar series serves as a platform to share innovative solutions, practical strategies, and success stories that address immunization challenges across Africa. Today's session will focus on how cutting-edge technology, localized approaches, and strategic collaborations are making an impact in reaching zero-dose children and improving vaccination equity. A few housekeeping items before we move forward. All microphones are automatically muted to minimize background noise. So we request panelists and speakers to keep their microphones muted when not in use. We encourage your participation. Feel free to submit your questions in the Q&A box at any time during the presentations. We will address all questions during a collective discussion session after the 3 presentations of the day. This webinar is being recorded for future references and will be shared with all participants. So let's get started with an engaging and insightful conversation this afternoon as we work together toward building stronger immunization systems for healthier communities. To begin, it's my pleasure to invite Dr. Andy Waziri, the Immunization Advisor at AFANET, to deliver the opening remarks. Dr. Waziri, over to you, please.
Good afternoon, everyone. I hope I'm loud and clear.
Yes, ma'am.
Okay, so I welcome you all to this exciting webinar series today. And for today's session, we'll be looking at technology. How has technology impacted our work in the vaccine? How has technology impacted our immunization uptake? We all know that despite remarkable strides that have been made in global immunization efforts, significant challenges continue to hinder our progress. Vaccine hesitancy, rooted deeply in misinformation and mistrust, remain a persistent threat. Logistical hurdles such as inadequate cold chain infrastructure, supply chain disruptions further complicate the delivery of vaccines, especially in the areas where we work, primarily remote and underserved areas. And perhaps most concerning is the inequitable access to immunization services leaves millions of people, especially in Nigeria, vulnerable to vaccine-preventable diseases. To overcome some of these challenges, we must embrace innovative solutions that harness the power of technology and further foster strong partnerships. Today's webinar will delve into these critical areas. One, decentralized immunization monitoring. I don't want to go deeply into what the presenters will be presenting, but then we'll explore how decentralized
Dr. Waziri, if you're speaking, we cannot hear you. Dr. Waziri, if you're speaking, we cannot hear you. Can you hear us? It seems we have a brief network. Can you hear us, Dr. Waziri? It seems we lost her. All right. Thank you, Dr. Waziri, for setting the tone for today's webinar. We at least got a little bit of an idea of what she gave us a background of what we're covering today, but did not go right into the details. So next we have welcome remarks from Dr. Heidi Reynolds. She's the Senior Specialist for Evaluation and Learning at Gavi, the Vaccine Alliance. Although she could not join us live, she has shared a recorded message. So let's listen to her remarks.
Hello and welcome to another webinar event as part of the Zero Dose Learning Hub webinar series. I am Heidi Reynolds and I lead the Learning Hub initiative and I work at Gavi, the Vaccine Alliance. My apologies for not being able to join you in person or live, I guess I should say. I'm grateful to have the opportunity to welcome you to this event, however. Really looking forward to these three presentations today. One of them is on the decentralized immunization monitoring work in Bauchi, Borno, Kano, and Sokoto, which is work that is conducted under the Zero Dose Learning Hub and has a really interesting component to be able to understand the performance of the routine immunization system in those states, as well as providing information to be used to correct for and improve performance. Also from AFANET, our colleague will discuss the use of technology to optimize the immunization in Katsina State, and our Ministry of Health colleague in Sokoto will discuss engaging the private sector to enhance immunization. This webinar series has been really rich in terms of the content, and so I encourage you to look for the other presentations that have been conducted. There's both the slides and the recordings, those are all available. But I do want to say just a few more words about the Learning Hub initiative, which is designed to help us build the evidence base about what works to prevent and reach zero-dose children and ensure that that evidence is used to strengthen routine immunization services. So the Learning Hub is not only in Nigeria, we also have partners in Mali, Uganda, and Bangladesh who are working on similar questions but tailored for their context. And I invite you to check out as well the materials that are available on our Zero Dose Learning Hub website, which is zdlh.gavi.org. We have a global learning partner who helps us disseminate and share the learnings from across the different learning hubs and other activities. So with that, I will just wish you a great rest of your day and encourage you to ask a lot of questions during the webinar. Make sure there's good dialogue and enjoy the presentations.
Thank you, Dr. Reynolds, for that recorded message. And yes, there was so much she said there. Please try and log on to the Zero Dose Learning Hub website. I'll repeat it for you, zdlh.gavi.org. There's a lot of resources on there from all the countries that are implementing the Learning Hub on Zero Dose. Now let's move on to our first session for the day. The first topic is decentralized immunization monitoring. Lessons from 4 states in Nigeria. This session will be led by Adam Atahiru, He is a senior monitoring and evaluation and learning specialist at AFINET. Adam has over 8 years of experience in public health practice and monitoring and evaluation. So he plays a key role in the Zero Dose Learning Hub Nigeria project, where he leverages data-driven approaches to enhance public health outcomes. Adam, the floor is yours.
Thank you, Margaret, and good afternoon, everyone. Please confirm if you can hear and see me.
Yes, we can.
I need permission to share my slides.
Presentation, please. Can you put it on slideshow for us, please?
Yeah, working on that.
Okay.
Please confirm you can see my screen clearly.
Yes, please go ahead.
All right, so good day, everyone. I'm called Adam Attahir. I work with AFINET as the Senior Monitoring Evaluation and Learning Specialist. So today I'll be presenting on behalf of the ZDLH Nigerian team, the Decentralized Immunization Monitoring, which was conducted across 4 states in Nigeria. This project is funded by Gavi and was implemented in close collaboration with the National Primary Healthcare Development Agency. So, as a way of background, the trend of routine immunization in Nigeria has remained suboptimal over time, with the NICS 2016 and 2021 reporting DPT3 coverage at 33% and 57% respectively. The most recent NDHS reported about 30% of children sampled with no immunization. To improve the coverage of routine immunization, the Routine Immunization Working Group, previously known as NERIC, had in 2023 prioritized 100 LGAs across 18 states with high number of zero dose to implement 2 major strategies. The first strategy centered around the zero dose reduction plan, also known as the ZDROP, and the IEV strategy, that's the identify, enumerate, and vaccinate. These 2 strategies are largely focused on identifying and reaching reach components of the IMA framework. To effectively track lessons learned, as well as the challenges that comes with the implementation of these 2 strategies, the DIM, that's the Decentralized Immunization Monitoring, was developed in close collaboration with the JSI and the Liverpool School of Tropical Medicine. This was piloted in Komboso local government in Kano State, sometimes in April 2024, and it complements the National Primary Healthcare Development Agency effort in monitoring and tracking reduction in zero dose in these prioritized LGAs. This approach was implemented in 2 LGAs in each of our 4 zero-dose learning hub intervention states. That's in Sokoto, where we have Wamako and Tambuwal, in Kano, where we have Kumboso and Sumaila, in Bauchi, we have Bauchi local government and Ganjua, while in Meduguri, that's Borno State, we have Jere local government and Meduguri LGA. This assessment aimed to provide better understanding of routine immunization performance, as well as to also document some key drivers of vaccination. Also to document some quick from what that needs quick intervention. The specific objectives include 1, to provide an LGA level estimate of key RI indicators, to also document some key drivers of low vaccination in those LGAs, provide an identified low performing wards for quick intervention, as well as to synthesize and disseminate the findings from this assessment into a usable document for the local government, the state, as well as at the national level towards improving uptake of routine immunization. We adopted the BESD framework, which was developed by the World Health Organization and was approved by the Strategic Advisory Group of Experts, also known as SAGE, on immunization, to provide contextual information about vaccination. This framework has been adopted in different countries to provide useful evidence-based information. This BESD framework comprised of 5 key components. The first component looking at thinking and feeling, which looks at vaccine confidence, looks at the emotions as well as the thoughts of individuals towards vaccinating their children, and this, as we understand, varies from person to person. We also, the BESD indicator also look at the second component, which is the social processes, which focuses on the roles family and friends, religious, community leaders, as well as peers play on the caregiver towards vaccinating their children. The third component is on motivation, which is the intention of the caregiver to actually get their children vaccinated with all the recommended vaccines. We have practical issues looking at affordability, ease of payment, among other potential barriers that may hinder the caregivers to vaccinate their children. The last component is around vaccination, which is the actual action where uptake of recommended vaccines actually takes place. So to achieve this assessment, we adopted a cross-sectional design approach, looking at all the wards in each of the 8 LGAs across the 4 states and focusing on 2 major cohorts of children, that's 0 to 11 months as well as the 12 to 23 months. The sampling technique adopted here was the LQS approach, where the LGA was adopted as the catchment area and the wards were adopted as the supervisory area. Across the 4 states, we have a total of 106 wards. Across these wards, 19 settlements were selected using population proportionate to size. So across the 4 states, we had a total of 2,014 settlements selected for this assessment. This PPS, that's the population proportionate to size, was actually done using the master list of settlements, which was provided by the LGA management team. In each of the settlements selected, households were randomly selected using what we call the segmentation approach. This entails working with a local guide, which has been identified by the community leader during advocacy, to draw a rough sketch of the entire settlement while documenting some key landmarks such as school, markets, police stations, rivers that one can easily use to divide the settlement into different segments. From the segments that were made in collaboration with the local guide, one segment was selected using the table of random number. In each of the settlement, houses were counted and they were also numbered. And again, using the table of random number, a single house was identified, which we refer to as the reference house. For implementation, the reference houses were not visited. Rather, the house closest to the reference house were visited to initiate sampling. In each of the houses that were sampling, only one caregiver was sampling, either 0 to 11 or 12 to 23 months. Once a child has been identified, the closest door to that particular house where the first child was sampled is visited to complete sampling of the second cohort. Across the 4 states, we recruited a total of 230 data research assistants. These data research assistants came with good knowledge of the Nigerian routine immunization schedule. They have good knowledge and use of the open data kit that was used in the data collection process, and also have a fair understanding of the terrain. These data research assistants were made to undergo a 2-day mandatory training where they were taken through the protocol of the survey. They were also made to understand the confidentiality and as well as the importance of data quality in the data they were going to collect. In each of the wards, we had 2 data collectors deployed, and they worked over a 6-day period. That's an average of 3 settlements per day. Now, going on to the key findings from this assessment, across the 106 wards where this was implemented, we sampled a total of 4,028 individuals, that's caregivers. And across these 4,028, the mean age of our caregivers was 28 years old, with a standard deviation of plus or minus 6 years. This was slightly found to be lower in Bauchi and slightly higher in Borno at 30 years. Over 97% of the caregivers sampled were Muslims and were married. The prevalence of zero dose was found to be 30.7%. The zero dose in this context comprised of children who had never received any form of vaccination at all, and those children who are over 10 weeks of age but had not received DPT-1. This prevalence widely vary amongst the LGA, ranging from Bauchi with 13.6% to Tambuwal with 53.8%. The blue bar showing the number of children sampled, while the orange bar shows the number of zero dose in that particular LGA. So across the 4 states, we also documented about 84% of the zero dose caregivers having no formal education, while 51% neither were engaged formally as a form of a job, nor were they self-employed. So this shows that the high number of zero dose caregivers do not have education, neither do they have a major source of income. Over 91% of non-zero dose caregiver at least attended one antenatal visit, while about 55% of the zero dose caregivers attended antenatal. This leaves a 45% gap, showing that about 45% of zero dose caregiver did not attend any sort of antenatal service. This was found to be high in Sokoto and in Somalia local government. Looking at institutional delivery, we also documented that only 40% of the caregivers sampled had institutional delivery. About 54% of these caregivers actually delivered at home, either by themselves or with the help of a TBA, or sometimes healthcare workers who actually direct the caregivers to go home and they will attend to them when the labor starts. This shows that 7 out of every 10 zero dose caregiver actually delivers at home. For immunization performance, about 73% of children sampled had never received at least one immunization antigen. Card retention was found to be high at 88%, and across the 4 states, DPT-1 coverage was estimated at 66%, and DPT-3 was estimated at 52%. To facilitate comparison with different surveys such as the NICS, the NDHS, as well as the WUNIC estimate, an antigen-specific analysis was conducted for cohort of children aged 12 to 23 months. And the findings were really very close to what the NDHS reported, which was 62.9% of DPT-1 and 53.4% for DPT-3, which was very close to what we got from DRM, which is 66% for DPT-1 and 55% for DPT-3. Looking at the behavioral and social drivers indicator, this study showed that about 94% of sample caregivers knows where to actually get their children vaccinated, but only 67.8% are willing to actually get their children vaccinated. In fact, among the zero dose caregiver, about 70% of the zero dose caregiver actually have little or no intention to vaccinate their children. This is a lot, and this shows a huge concern that needs to be addressed as soon as possible. 3 out of 10 caregivers reported not trusting the healthcare worker that actually vaccinated their children. This was also found to be highest amongst the zero-dose caregiver. This underscored the importance of healthcare workers as it can influence caregiver decision to vaccinate or not to vaccinate. Vaccine importance stood at 78.2%. About half of these zero-dose caregivers do not believe in the importance of vaccination. When asked about affordability, about 53.7% reported that it's easy for them to vaccinate their children. But when this was compared with the logistics involved in getting their children vaccinated, we actually realized that about 60% of the zero-dose caregivers actually reside within 5-kilometer radius of a health facility, as shown on the next slide. This is a case study of Komboso local government, showing 3 distinctive features. One, we have the geo coordinates of the children sampled. The green shows those that have ever received vaccination, while the red shows those that have never received vaccination at all, while the red cycle with a cross shows the location of the health facility. We have a yellow buffer around each of the health facilities showing the 5-kilometer radius. And from this, you can see that all the zero-dose students fall within the catchment area of a particular health facility. Using the LQS approach, we've been able to prioritize 72 out of the 106 LG wards within the 4 states where this was actually implemented. And these are the prioritized wards. Some of the challenges that we encountered during implementation include: 1, our inability to track vaccination of identified zero-dose. So during implementation, we actually came across a lot of zero-dose which were referred to the closest health facility for vaccination. But because we were not funded to vaccinate, so we were not able to actually track if those children actually got vaccinated. This is a key area that if funding is available, we can actually ensure that as those children are being identified, they're also being vaccinated. We also had issues with the list of master lists that was provided by the LGA, where some of those settlements were either misspelled or never existed as documented on their plan. We also identified Islam-dominated areas, since we worked in the 4 states where we worked are predominantly in the north. Most of the caregiver sample were predominantly Muslim. So we're unable to establish any relationship between religion and zero-dose. This is my last slide. As for recommendation, it's important for us to also scale up this DRM in other zero-dose LGAs so that we can establish a baseline in all the 100 prioritized LGAs, and we can easily track. The second recommendation is to ensure that we capture all zero-dose that live around the health facility so that they can probably using a walkthrough so that we can quickly increase our coverage. This will be a quick win for this local government. It's also important to strengthen community-based monitoring and tracking approach. Although administrative data exists, well, it's important that we strengthen the RISS that's currently being implemented towards monitoring the performance of settlements and wards as against LGAs and state. Reduction in zero-dose also needs to be at the prenatal care, looking at the ANC and institutional, probably as the relationship shows, increase in institutional delivery and ANC will automatically increase uptake of routine immunization. As client-centered approach is a key opportunity to explore. My last point is also to develop strategies towards improving the relationship between the caregivers and the healthcare workers, improving the quality of care that is being provided by healthcare worker, and health promotion will really go a long way in improving trust between these 2 major drivers. Thank you very much. And these are some of the pictures over Margaret.
Thank you so much, Adam. Thank you for being mindful of our time. Yes, I agree with you. The recommendation to scale up DIM, the decentralized immunization monitoring plan that you have, to other zero-dose LGs. Thank you very much for those insights once again. We jump right into our second session, but before we move ahead, I'd like to just say that for those of you that have questions, we have a Q&A box at the bottom of your screen. Please click on the Q&A box and type in your questions. The speaker or the presenter will be able to respond to your questions live. And also in the discussion session after the 3 presentations, we will still take your question. So moving on to the second session for the day, leveraging technology to optimize the uptake of immunization among zero-dose and under-immunized children in Katsina State, which is in the northwest of Nigeria, 2024. This session will be presented by Ramatu Obansa. She is the lead for the DHIS2 project at Afinet, Nigeria. With over 13 years of experience in health systems strengthening, Ramatu has made remarkable contributions to health in Nigeria. Ramatu, we are eager to learn from your experiences. Over to you.
Thank you, and good afternoon, colleagues. So as rightly introduced, my name is Ramatu Obansa, and I'll be taking us through the pilot we did in Katsina, in a particular ward in Katsina State, on leveraging technology to optimize the uptake of immunization services among zero-dose and under-immunized children. So I'm just trying to share my screen. Could you confirm if my screen is on and if people can hear me?
Yes, we can hear you. We can see your screen. If you can just put it on presentation mode.
Yes, working on that.
All right.
Okay, is that fine now?
Yes, you're good to go.
Okay, thank you. So, colleagues, I'll be sharing with us the pilot project we did in Yamatu Ward in Katsina State around using technology to, improve the uptake of immunization services among zero-dose and under-immunized children. So this was actually implemented on the platform of GIGS. Yeah, so this outline will be guiding my presentation. So talking about GIGS, I had mentioned earlier that we implemented this project in Yamotu Ward in Katsina State on the platform of GIGS. So GIGS is Growing Expertise in E-Health Knowledge and Skills, which is a one-year fellowship program where we build the capacity of government staff. So we actually identify staff from Federal Ministry of Health, MPHCDA, NCDC, and even NAFDAC, and build their capacities around data management, robust data management, and health informatics. So it works such that as we build capacities, as we build skills of personnel, we also give them projects to implement. So that's how we implemented this particular project in Yamotu Ward in Katsina State. It was one of the projects that we implemented during the recent cohort 4 of the GIGS fellowship program. So just as a way of background, a zero-dose child is that, these are children who have not received the first dose of Penta, DPT as other countries call it, and then an under-immunized child is that child who has not received the third dose of Penta. So, this population, nearly 50% or more of them reside, within the conflict settings, remote communities, and even urban slums. So Nigeria actually accounts for the highest global burden with an estimate of 2.1 million zero-dose children. So the problem over time has been that we have estimates, at the state level, national, and even LGA of these zero-dose children. But as at the time this project was conceptualized, we did not have sufficient data in country showing where this particular population reside in the health facilities or in the settlements. So that remained a challenge, and that was how we conceptualized this pilot to see how we can support the efforts of government in identifying and seeing and linking these populations to routine immunization services. So part of our objectives were to conduct a walkthrough enumeration to identify and list the zero-dose and under-immunized populations, and also see how we can use satellite imagery to improve the identification and reach of these populations in the settlements, and also to link them to routine immunization services using coupons and the line list. So this is our approach. We had the identify, enumerate, link, and assess. So just to mention, colleagues, that we had conceptualized this before government came up with the IEV. So ours was more of IE, L and A. So we wanted to identify where these households are, where the households where this population reside, enumerate, line list them, particularly children under 5 years of age, and also see how we can link those children who will be identified as zero dose or under immunized that are below 2 years of age to routine immunization services. So having done all this, we also thought it would be necessary to assess, to kind of find out or even see the impact of this whole project. So did the linkage work? So we needed to also conduct an assessment to find out the vaccination status of the children. So now we're going to share how we did the identification. And here we would like to mention that we would like to talk about the use of GIS technology. So we worked with consultants from the University of Southampton, they are GIS experts, to be able to develop a geospatial map for the ward, the Yamatu ward, using OpenStreetMaps and Google building footprints. So with that, we tagged all the structures on the map and we delineated the ward into 197 enumeration areas to ease the work, and identification of structures. And also we came up with, using the satellite imagery, we came up with 8,022 structures. So we also had maps developed for each EA. The red annotation you're seeing here is just what a typical enumeration area looks like. So now moving into enumeration. So we, of course, before we went to the field to collect data, we had engagements and we partnered with key stakeholders at the state and LGA level to even understand, some contextual factors and, gather some information before the pilot proper. So we identified and trained ad hoc staff. We formed 22 enumeration teams, and this comprised of 3 persons: one, the enumerator, the navigator, and the community leader. So we also trained and deployed independent monitors just to check, the work that the teams will be doing. We trained team on using ODK for data collection, and we also have an in-house tool we call the EMIDAS, the electronic management of IEV data system that we use for navigation to all the enumeration areas and structures. So we also used we printed maps just to ensure that there's accurate delineation of the enumeration boundaries. So that was how we collected data for children under 5 years of age. And where we in households where we found under immunized or zero dose children, we provided health education, kind of sensitized the caregivers. So moving to how we linked this population to routine immunization services, we have what we call the coupon, as we mentioned earlier. So this is a booklet, containing the name, the age, the address, just some vital information of any child who is identified as a zero dose or under immunized. So, and this, we actually learned a lesson from one of the states in Nigeria, particularly Borno, where, this is a kind of ticket that is given to a caregiver, to refer her back to a facility for her ward to be vaccinated. So we actually printed in triplicates, gave a copy to the caregiver, another copy to the facility, and 1 copy to the community leader. So we also had line lists. So from the data we collected, we generated a line list that was given to the state, the LGA, and health facility to ensure that these populations are reached using optimized immunization strategies and every opportunity. So moving to our result, we would like to share with colleagues that this shows the spread of the structures that we're able to enumerate at that level in Yamatu ward. So you would notice the yellow dots are structures that we identified using the satellite imagery, while the blue dots are the structures that we actually visited. So we had more structures visited than we identified. Of course, that is expected, that physically on the field, we're able to enumerate 10,250 structures, which is, quite more than the structures that we identified using the Google building footprint. So looking at this, a total of 4,385 children were enumerated, with under-immunized children less than 2 years of age standing at, 299. So for also the zero dose children between 24 to 59 months, we had 55% from the total children enumerated. So for zero dose, we had 19% of that. So this map shows us the spread of this population, the zero dose and under immunized, and we tried to even draw a 2-kilometer radius buffer over this map. And colleagues, you would see that this population actually resides just within 2 kilometers to the 4 health facilities in Yamatu ward. yet we have children who are zero dose and under immunized. So these are some of the implications of our findings from the enumeration. Like I mentioned earlier, we have people residing within 2 kilometers or even less to the health facilities, but yet we have 32% children who are either zero dose or under immunized. So we thought there is need to actually, optimize the RI strategies, maybe do more of this house-to-house vaccination, and also we also have children who we identified between the age of 0 to 5 weeks who have not received any form of, not even the birth dose vaccines. So these children could also form potential zero dose if they are not followed up. So we also, part of the reasons caregivers gave for not vaccinating their children included the head of household not giving permission, and also, some caregivers not seeing the need for their wards to be vaccinated. So moving into the assessment. So, I'd mentioned earlier that we identified, we enumerated, and we linked. So we went back to conduct an assessment to see the level of linkage, or if those children were actually, taken back to the facilities for vaccination. So we used our in-house tool for navigation. So we already have where this population resides. We have the geo coordinates and all. So we went back to this household to ascertain the vaccination status of these children. We identified ad hoc from the team we had used for enumeration and trained them on how to conduct the assessment. So we also provided a line list of these zero dose and under immunized children by settlement to ease the work of the team, to ensure that the right households are identified and assessed. So we also did an assessment at the health facility level to see how the coupons were retrieved by the health facility staff. So moving on to the findings from our assessment colleagues, this map actually shows the structures that we visited during enumeration, and this is represented by the red dots, while the green dots shows the structures that we actually visited during the assessment. So colleagues, you notice that, these dots are actually overlapping, so that kind of shows us that to a very large extent, the structures that we identified during enumeration were actually the same structures that were visited for the assessment. So here I would like to share with colleagues that 73% of the populations that we identified during enumeration were able to assess. So we're not able to assess 27% due to issues like insecurity. You will see that we've annotated a particular area that our teams couldn't go to because of insecurity. So other reasons were migration, relocation, or the absence of the caregivers. So this also is a summary of what transpired during the assessment. Of the 627 populations we identified, or children we identified as either zero dose or under immunized, 75% of them were assessed. That's for the zero dose. 75% of the zero dose population we were able to assess. And of this number, 149 were actually vaccinated. Now, looking at children under immunized, we're also able to to assess 71%, giving us, this is 211, that's 71% of the population we identified as being under immunized during the enumeration, and we vaccinated 71% of them. So we'd just like to say that, bring this out clearly that 61% of these zero dose children have received at least 3 antigens from the time post-enumeration. So we'd like to share just some of our lessons learned with colleagues. Yeah, so here, using a very recent satellite imagery was very helpful in ensuring that we did accurate delineation of enumeration areas. We also had community acceptance because we used already females that are, resident in that particular ward, and they also have been conducting the house-to-house polio vaccination over time. So our coupons also really came in very handy in ensuring prompt linkage of the zero dose or under immunized children to health facilities. So these are some of our recommendations to the state. So, with the work that we've done, it shows that just as we keep making efforts to ensure that children are taken back for vaccination, it will actually yield results. For the state, for example, we had recommended that they support the LGAs to ensure we still have a pocket of these populations that have not been vaccinated, just like our data showed. So we feel the state also needs to support the LGAs and health facilities to ensure that these children are vaccinated. So the LGAs, we also recommend they, facilitate quarterly regular review of the micro plan and also, help the facilities to optimize their session plans. And for the health facilities, we hope that the line list we provided, they will use them to ensure that these children actually complete their immunization, and those who have not started also are tracked to ensure they are vaccinated. So, just sharing some of our successes. I'd mentioned earlier that during the enumeration, by the time we had spent first, second, third day, we were already seeing copies of the coupon in the health facilities, meaning that the caregivers, were taking their wards back for vaccination. They were motivated to do that. And then would like to also, bring out clearly, colleagues, that without any monetary incentive also, just leveraging our, community engagement structures and the optimization of routine immunization services, 61% of the zero-dose children and 71% of the under-immunized children that we assessed during the enumeration received at least 3 antigens in the health facility catchment areas. So these were just some of our limitations. We had boundary dispute, which resulted to 1 enumeration area not being enumerated. And then during the assessment, we also have 27% which were not assessed, like we presented in our earlier result. So colleagues, these are just some of our picture gallery, just to mention to colleagues here that we really had acceptance and state ownership of this project, because the first picture you're seeing here is even the executive secretary of the Katsina State Primary Healthcare Board. We also had the incident manager, the SIO, and a lot of the key stakeholders at the state level participated in these activities on the field. Thank you very much.
Thank you very much, Hadia Ramatu, for that enlightening presentation. Yes, and thank you for showing us how to optimize technology to identify, enumerate, link, and vaccinate and link zero-dose and under-immunized children. Thank you very much for that presentation. We move on very quickly. Please put your questions, drop your questions into the Q&A box at the bottom of your screen. We move on very quickly to our third session for today, which focuses on engaging the private sector to enhance immunization access and coverage among zero-dose children in Nigeria. This session will be delivered by Dr. Abdul Rahman Ahmed from the Ministry of Health, Sokoto State. Dr. Ahmed is a seasoned public health specialist with over a decade of experience. His achievements include establishing a maternity waiting home and collaborating with global organizations like WHO and UNICEF to improve healthcare delivery. Dr. Ahmed, you're welcome. The floor is yours.
Thank you very much, Margaret, and good day to us all.
Good day to you too, sir.
Yes, thank you. So I'll get the presentation from your end, right?
That's right. We'll be projecting for you.
Ahead? Okay.
It's coming up, sir.
So good day, everyone on the call. Taking us through engaging private sector in enhancing immunization access and coverage among zero-dose children in Nigeria. So I want to begin with the private sector is that part of economy which is not controlled by government, so which includes the corporations and companies, whether multilateral, multinational, or local companies, non-governmental organizations, the CBOs, professional bodies, including the consultancy firms and the rest of them, individuals, the philanthropists, the well-meaning individuals that are organized or in person coming together to see the progress of the society, which is actually not the government. So then when we go to zero-dose child, zero-dose child is a child that has never received any immunization at all. But we have more liberal definition by Gavi, which is looking at a child who has never received any diphtheria pertussis containing antigen, which in Nigeria we refer to Penta. That is what we give for children, and DPT is for pregnant women. So either way, this is in a nutshell a zero-dose child. Zero-dose children are key indicators of inequality in health access, and addressing those inequalities and the population of zero-dose is very, very essential for ensuring universal health coverage and reducing childhood mortality and preventing outbreaks of vaccine-preventable diseases in any society. So that we are localizing this to looking at Nigerian context. Next slide, please. So when we look at it, Nigeria has a very big burden of zero dose. When we look at the first definition of a child that has never received any dose, Nigeria is estimated to have 3.5 million of such individuals. So that when you look at the child that has not received diphtheria containing antigen, that you are talking about 1.9 to 2.1, depending on the estimate that you are looking at. And this is among the highest globally when you compare to any single country to have this, even when you take proportionately. I know Nigeria is one of the countries with high population, so that even proportionately, Nigeria has the highest burden of zero-dose children. And when you look at Nigeria as well, where I'm sitting, which is Sokoto, which is located in northern part of Nigeria, has the highest burden also when you segregate it by region. So this is worst when you look at the rural, hard-to-reach and conflict affected areas, which not generally, when you look at the northeast, we have Boko Haram, northwest, we have banditry and other armed conflicts going on in the region. So which is compounding the inherent issues with the zero dose that we are having. So low immunization coverage contribute to the high number of underpipe mortalities and recurrent outbreaks that we keep recording, which as we speak, Sokoto is battling with cholera as we speak, among other outbreaks. Though cholera is vaccine preventable, but it's not routinized yet, so that the vaccine is available. So can we see the next slide, please? So what are those barriers to routine immunization or immunization coverage generally in the country? We have health system constraint, which include the governance issue. We have a lot of plans, a lot of documents, but when you look at the accountability, it's lacking. We may have a good policy, but no good implementation plan for those policies, or even if the implementation plan is there could be lacking in the political will to implement those policies to the latter. So, which is actually affecting the health system greatly. Coupled to the fact that also limited funding. Nigerian health system is donor-driven, unfortunately, and donor fatigue is setting in, which we can see clearly. So all these things compound to the health system challenges that we are having that pertain to the governance. Aside that, we have supply chain gaps. So where inherently we have remote areas, hamlets, which are nucleated from one place to another. So some of which even with the motorbike is difficult to penetrate. So these are also compounding the supply chain issues because even if you have commodities, you need the last mile distribution for the service providers to be able to do the work. So it's one of the challenges that is hindering the immunization coverage in the country. We have shortage of human resource for health, which are the healthcare workers, complicated by the fact that even the ones available have one capacity gap or the other to be able to do what is expected of them to move the needles of immunization in the country. This is also complicated by geographic and infrastructural challenges. As mentioned earlier, we have remote areas that are hard to reach. Some, even with the motorbike, you cannot go. Some, the rivers are cutting them from the main town and where the health facilities are located, and the rest of them. And some of the health facilities located are dilapidated because of the insecurity or funding gaps. Some of them are inhabitable. Some has no storage capacity to keep the vaccines that will reduce the back and forth movement of the vaccines. And also in this fact, we have shortage of the fast and the slow cold chain equipment, so which is all compounding to the challenges. The next challenge is the cultural and social factors, which mistrust in government trust and partners driven activities is all over the place in the country, as we see in the southern part of Nigeria, where people reject normal vaccination because of mistrust that they are going to be given monkeypox vaccine. So in the northern part of the country, they believe, they don't trust the system that if vaccine is given is to reduce their fertility and the rest of it. So there is mistrust. And the cultural beliefs that some quarters of the society is still believing that their religion did not allow them to take prevention, that they have to wait until they are sick before they seek medical care. Amidst a lot of other cultural beliefs that is hindering and impinging on the healthcare system. So lack of awareness, in fact, on the vaccine acceptance, where you see because of the governance system issues, the people that are supposed to do awareness in the system, we do it the way they want, not following theories of change that will ensure the community are fully aware and sustain the awareness for them to be craving for the vaccine, not that they will have to be pushed every day when campaign or any intervention is going to take place. The latest issue that is impeding on the immunization coverage in Nigeria is the ongoing security challenges across virtually all the states, or let me say most of the states in the country, awarding in the northern part of the country where you have the Boko Haram, bandits, and cattle rustlers, among others. So this is also creating more barriers where health workers, logistic teams cannot move freely to take commodities there for service provision. So next slide, please. Okay, so there are a lot of effort put in place in Nigeria by government and partners to see that the immunization coverage is improved. So, which include the National Immunization Strategy, which aim to improve immunization coverage via routinized immunization and also the supplemental immunization of any kind. We have partners that are interested in immunization, which include WHO, which the money for the logistics and allowances for the supplemental immunization teams are coming through, and also the support for supportive supervision and other component of routine immunization. UNICEF, which is supporting majorly with communication, and also a new intervention through UNICEF, which is immunization education integration project, which is being piloted and is still ongoing, with its impact being felt in where it is being implemented. We have Gabi implemented Z-Drop as an effort to reduce or eliminate the zero dose in the places that is being implemented. APINET supported many states with SMS RI reporting, where scheduled routine immunization are being recorded and when implemented also are being shown. National primary health care come up with an intervention, identify, enumerate, and vaccinate, which is also being rolled out. Security intervention to cover, especially for the polio intervention. We have also community engagement, where we have community engagement strategy, where my Anguas go and do line listing of the newborns to ensure that they are linked up with health facility for vaccination. So among other interventions that are put in by government. Next slide, please. We have documented success of private sector support in Nigeria, where telecom partners help with alert to remind caregivers of their scheduled immunization and also health education. We have transport sectors in different places supporting in delivering vaccines and other commodities to the last mile free of charge as part of their support to the system. Pharmaceutical companies supporting in donation of vaccines to boost availability, among other humanitarian support. Corporate social responsibility by banks to support in immunization activity and other child health campaigns. Next slide, please. We have local here in Sokoto, what is initiated this year, which is very promising that we can leverage on as a country to see how we move on. There is what we call Tambuwal initiative. So where current government officials gather themselves and said issues in Tambuwal must stop. They move in to mobilize communities in Tambuwal, influential people, to say that rejection in Tambuwal for supplemental immunization must stop. So the mobilized people donated money among themselves and moved to talk to colleagues, and then any household reported as non-compliant, the organized people within Tambuwal go and contact the person, understand why he is rejecting the immunization, and then eventually at the end of that round, there was zero pending non-compliance or child absent in Tambuwal local government. So which is something that the country can leverage on to see that is institutionalized among areas with issues. There is what we call Tunga model. So Tunga model, Tunga is a village in Kware local government, Sokoto state, where over 90% of the dwellers are farmers, either subsistence or commercial farmers. But they are faced with challenge of stealing of their crops while it is in the farm. They organize themselves that this thing must stop. They reach out to government, police, civil defense, and the rest of them. So they get support. And today, as I told you, you can leave your commodities, farm commodities in your farm with nobody touching it. This is to show if communities are enlightened, they came together, they can be able to solve a lot of issues by themselves. Next slide, please. I'm almost there. Hello? Okay, I'm done with this slide. I'm done with this slide. Okay, so potential areas to enhance is the governance, funding and sponsorship, as I mentioned, if policies can be developed, accountability framework attached to it, financial backing given, a lot can be done. Cold chain, private sectors can be engaged locally at the state level to see that commodities reach last mile with support from the private sector. Leveraging on data and technology solutions, as the second presenter done, if those are emphasized, it will do a lot. Media and public awareness, this can do a lot also in ensuring improvement in vaccine coverage in the country. Next slide, please. Okay, so proposed model, public-private partnership, this can work alone a lot, focusing on immunization. It can improve the infrastructure and also last mile distribution of the vaccine at minimal or reduced cost to the government and partners. A performance-based contract, also if this is done, this can help a lot. Corporate social responsibilities, companies and other sectors can be pushed to take immunization as part of their social corporate responsibility agenda. Innovative financing, like impact investing, social impact bond, blended model of immunization, all these things can support to enhance immunization coverage. Maybe I'll stop at the next slide, please. See it. Okay, so we have case studies of successful engagement. Gavi Business Network is something that is, Gavi's Business Network is initiative to bring funding from different sources to support immunization effort in low income countries, which is doing a lot in ensuring that child survival is improved. M-Pesa Health Initiative in Kenya is a mobile banking system in Kenya, which came up with initiative to support immunization through payment reminders and other components of the initiative. So UNICEF supported partnership, also support in cold chain equipment, vaccine sourcing, and also mobilization. So among cohort of other successful ventures that are documented and still going on globally. So if permitted, I can continue, but I can't stop here.
Please continue, Dr. Ahmed. Please continue.
Okay. Okay. Thank you. So next slide, please. Okay. So we have key consideration if we want to have effective partner private sector engagement in Nigeria, which include policy and regulation. As a country, we need to develop policies, and not only policies, but having good implementation plan for those policies and good accountability attached to them, because the policy will not implement itself. The policy implementation plan will not implement itself. We need to have accountabilities for those policies and documentations that we may develop, or looking at the existing documents. So then clear roles and responsibilities. We need to define roles to maximize impact and avoid overlap between government, partners, either individuals, companies, donors, NGOs, or any other person. So once we have that, we may have multiple interventions from different donors, but once there is accountability and clear roles and responsibility for each one will be playing his role, but eventually will converge and have maximum impact. So data sharing and coordination. If multiple people or even two people are working, but without communication, there will be a lot of conflict, and result will be negative energy for each other. So coordination and data sharing among all, not some, among all partners that are implementing similar projects or activities will help a lot in ensuring improvement, which will reduce duplication and enhance synergy for maximum impact of all the intervention. Community trust and engagement. When, as I mentioned with the Tunga model, if communities are sensitized and they took it as their responsibility, the issue of trust is gone. But coming up with any intervention that you have to communities for them to take, they will not take it because there will be trust issues. But when communities are the one craving because of desensitization and how we enlighten them to understand it, and all the interventions that are to come has to be culturally sensitive. We can't have bundle intervention coming from the center. The interventions have to be specific. And if we can theorize them, meaning we base them on theory, any available theory of change, or example, social cognitive theory, proceed model, health belief model, this surely we will be able to change our communities and build trust for them, and we see more impact in all the interventions we do in immunization and even beyond. Next slide, please. I think this should be my last slide. Yeah, benefit of engaging private sector is one, private sector has wide reach. As I define the private sector is anything outside the government. So there are individuals, civil societies, organizations across board. We have official and unofficial organizations, women group, Adashe group, and all the rest of them, market women. When we penetrate through those ones, they are everywhere. And when you breed trust in them, they understood what we need and why we are doing what we are doing. They will be the advocate of change. And they are in underserved communities. They are in the remotest of the remotest societies. So we have wider reach. It will be a source of additional funding, technology, personnel. We have people, healthcare workers who are willing to support immunization activities, and they are not working with anybody. They just schooled and they have something doing, they continue. But if engaged, we have full of manpower to leverage on to do service delivery in immunization and other intervention. Private companies bring innovative solutions, logistics support, communication, and other needed support that is needed to reach last child, last mile, and all that needed the interventions that we have. Lastly, private investment can lead to lasting infrastructural improvement, which will be sustainable. I can remember the PHC summit done where Dangote and other philanthropists come together to adopt PHCs in their domain continuously. So if this is harnessed, I'm sure we have with time more improved infrastructure, more improved service delivery to the extent that we'll be looking for zero dose and we will not see it when appropriate engagement of the private sector is actually done. Next slide. This should be my last slide. Okay, so this is my last slide. In conclusion, engaging private sector is very crucial in tackling zero dose challenge in the country. It will help us in establishing partnership, develop clear frameworks. And if we are to do this, it is good that we begin with pilot project on high priority areas to see how we can expand the Tambuwal model, the Tunga model, and the like. So which, if done, we can globalize it across all the segments of the society. With private sector involvement, Nigeria can expand immunization access and save lives by reaching every child. Thank you. I have further readings if anybody is interested. Thank you very much for listening, and sorry for taking longer time than what was allotted to me. I'm very sorry.
Thank you, Dr. Ahmed, for your insights on engaging the private sector for immunization access and coverage. I like when you said that we will not see zero-dose children if we effectively engage private sector involvement. I'm sure they're all here, our participants, and we would have fruitful networkings and collaborations after these sessions. Thank you, Dr. Ahmed, once again. We now move on to an open discussion session and experience sharing. It's an opportunity for everyone to ask questions, engage, and share their perspectives on the presentations that we have heard today. Please feel free to raise your virtual hands or use the Q&A box to share your thoughts, drop your questions. However, to ensure we hear from as many participants as possible, we request that you keep your contributions as brief as possible due to time constraints. Longer comments may need to be cut short, and we thank you for your understanding. With that, let's jump right into the discussion session. I have some questions here. I have some hands raised. Safia Zubairu Kataki, please unmute yourself and share your contribution. Safia Zubairu Kataki.
Thank you very much. Thank you very much. Please, am I audible?
Yes, you are. Please go ahead.
Good day, everyone on the call. My name is Safia Zubairu Kataki, Fagi LGA, Kano State. My Fagi LGA is one of the metropolitan LGA that has most of the international markets situated in it, like Quarry Market, Sabangari Market. So we have high influx of people every day in the market. Although we have some strategies for reaching out zero-dose children during in-between round activities and SIEs. We usually deploy market teams to vaccinate eligible children on daily basis at the entry and exit point of the market. I am concerned about the zero-dose in the market. I am seeking for your technical advice if there are other strategies to reach out those zero-dose children in the market. Thank you and over.
Thank you, Madam Safia. I suppose the question was directed to the first speaker, right? Adam, I think that question was for you. Please take note. Let's take the next question from Jamila Buhari. Kindly unmute yourself and ask your question. Jamila Buhari. Moving on to Rukaya Lawan. Rukaya Lawan. Kindly unmute yourself and your contribution, please. Rukaya Lawan. Rukaya Lawan.
Hello, am I audible?
Yes, you are. Please go ahead.
Okay, thank you, ma. Mine was just a question. My name is Rukaya Lawan Mohammed. I'm the NSLO from Dawakin Tufa and Minjibir LGA. Mine was just a question about this zero-dose engaging community activity. What are the strategies? What are the AFNET strategies and steps employed to enhance community engagement, improving health facility readiness, and ensure the delivery of vaccination to underserved population? That was my concern. The engagement of community. How will the community be properly engaged in all those activities and ensure that all the zero doses are reached in the community? Thank you. Over.
I believe your question is for the first presenter, right, Madam Rukaya? Adam, I think that question is for you as well. Moving on to Dr. Murtala Ahmed. Dr. Murtala Ahmed. Bafa Dati Guarzo. Bafa Dati Guarzo. Please unmute yourself and share your contributions. Bafa Dati Guarzo, can you hear me? Bilkisu Abdullahi. Please go ahead with your contribution. Bilkisu Abdullahi. We'll have to move ahead. Mustafa Yushau. Mustafa Yushau. Mustafa Yushau, your contribution, please. It seems we have an outbreak of raised hands.
Am I audible?
Yes, yes, you are. Go ahead, please.
Yes, my name is Mustafa Yushaw, NSLO of Alcaleria and Kirfi LG of Bauchi State. My question is, what makes decentralization immunization monitoring different from other surveys like LQAS? And how effective is it in monitoring the reach of immunization services in resource-constrained settings? Thank you, and over.
All right, thank you very much for your question. We'll have the first speaker respond to that as well. I'm looking at the Q&A box, and there's a question here. It's quite a long question. It says from Nura Mohammed Waronio. It says, in order to have more coverage to immunizations, especially routine immunization, why are the strategies used in campaigns not being implemented in conventional routine immunizations? For example, a lot of demand creation is being carried out in order to have acceptance, such as community dialogue, compound meetings, and sensitization, which is being funded. Why not RI? That's a good question there. I think we can take these first round of questions before we go ahead into a second session, a second round of discussions. Adam, please, you may unmute yourself and respond to those questions that were asked.
Thank you, Margaret, and thank you all the participants for these very insightful questions. I think most of the findings that we have presented, it's actually meant to generate, some debate on how we are actually implementing some of these activities at our local level and what we can actually do differently towards improving. As we implement, we learn, and those learning are actually being put back into the process of all the implementation process. This is a process referred to as adaptive learning. So I will attempt to respond to some of the key questions that have come up. The first is by Sefia Zubairu, who asked about improving market vaccination. I think market vaccination is a very good innovation, and it would be good if you can actually have some sort of, analysis if you have the data that is coming from those vaccination points. One key recommendation I would like to provide on that is for you to actually look at, because Sabongiri and most of those international markets, as you have mentioned, are actually a big market. And probably there is a central area where most of these caregivers are actually going to. So it will be good for you to also, using the data that you have, to generate some insights, looking at where do you get most of these vaccinations from those markets, and how can you, do you need to actually deploy more teams to those places where you have high report, because the essence of the vaccination at the market is for us to be able to reach as much children as possible. So using data to strategize the number of teams you need, using data to be able to understand where actually give you more impact, using data to further understand what the requirements for those markets are, I think are critical things that you might need to look at internally. I don't think I have a better strategy than the deployment of the team, but further understanding that process will really go a long way. Rukayat asked the question, how can we strengthen the engagement of communities, and what is AFINET doing to actually support some of these reach of zero dose? I think as Ramatu has presented, those are very innovative strategies that we are hoping that some of these states' leadership can actually support, strengthen, and see how we can also, strengthen the implementation. We believe that there are quite a lot of capacity, both at the state and at the national level, to also support this process. But there are some financial components that probably the funder or the states might need to to really step in to support. With regards to engagement of the communities, I think it's important that, and I think this has also been stated in the IA 2030, that different problems in different areas and they require different interventions. It is key for us to understand what are the problems of those community. So we have been carrying out community engagement. What are the problems? Understanding those challenges will really help us in strengthening what is happening and what we actually need to do. From the analysis that we have done, we've realized that one key area that we really need to strengthen in community engagement is in the area of engaging heads of households. Most of the routine immunization demand generation activities that we develop, the IEC material that we develop is targeted towards the women. And for us to get the children vaccinated, the women need the consent of their husbands to take those children for vaccination. Shouldn't we be thinking of how to redirect those engagement, all those sensitization to the men? I think these are one of the key areas that we need to improve on. Another area is in the area of involvement of community engagement. I know a lot of states at the local level, even the LGA, have actually been implementing this, but we need to still evaluate and see what are we doing right, what are we not doing right, and how can we improve on these processes. I believe that engaging the community as part of the development and the implementation of some of these strategies will really go a long way in ensuring sustainability and then taking ownership of some of these strategies. Mustafa Yau, very insightful question. Thanks for that. What differentiates the decentralized immunization monitoring from other surveys? I'd like to call your attention to the fact that most of the surveys that are being implemented always estimate coverage at the state level. However, we all know that all these local government in the states, take for instance in Kano State where we have 44 local government, the coverage of just a single figure saying that Kano has a DPT coverage, DPT1 coverage of say 50% does not really, does not really show that all the LGAs at 50%. There is need for us to understand what the coverage of these LGAs are and which LGAs do we need to actually prioritize. This information will really help us in gathering the resources and tailoring the scarce resources into where they are actually being needed. That's one of the advantages of the DIM. Looking at the LGA, estimating the coverage, and also identifying some of the priority wards that we really need to intervene. The second advantage of the DIM is around the ease of implementation. Most of these surveys, like NICS, happens annually. At the NDHS happens every 5 years. We need information for us to iterate some of the findings into what we do on a daily basis. DIM provides us data every quarter, in some places every 6 months, where we can quickly monitor the trend of routine immunization and how we can incorporate some of these lessons that we have learned into what we are doing so that we are able to reach the 2030 targets for the country. We have adopted very good strategies in terms of sampling. What we adopted was a random sampling approach, which we are sure is representative, at least in those LGAs. So we're able in that particular LGA, we're able to generalize what our findings are. I think these are some of the quick response to your question. We are trying to work with the states and at the national level to see how we can incorporate some of these questions, streamlined questions into the supportive supervisory checklist, and from time to time we are able to get this data on a continuous basis. Using this approach, we might not need funding to actually implement or so we might not need huge funding to implement to get the data so that we can continue monitoring, but it's very important that we get up-to-date, reliable, community-based data to actually track the reduction on the zero dose, as most of the implementations are concurrently being implemented, such as the G-drop, the UNICEF activity that Dr. Abdurrahman mentioned, and other lots more interventions. How are we sure that they are actually getting to the right beneficiary? How are we sure that we are reading zero dose? These are questions that the DRM can really help us to answer. Thank you, and over.
Thank you very much, Adam, for those responses. I have some questions here from participants for Hajia Ramatu. It says, why was it necessary to divide the settlements into enumeration areas, and how useful was this approach in your work? Another question here for Dr. Abdul Rahman. It says, how can Nigeria leverage on the 2 local initiatives mentioned in the presentation to reduce the zero-dose children? Another question for you, sir. It says, there are a number of initiatives that work globally but have minimal impact when applied in Nigeria. Why and how can Nigeria maximize the impact of interventions? Another question for Hajia Ramatu. It says, card retention appears to be quite low in some of these settings, especially children above 2 years. What methods did you use to gather information on the vaccination status of children whose vaccination cards were unavailable during your enumeration exercise? I'd like to call upon Dr. Abdul Rahman first to respond to the questions, followed by Hajia Ramatu. Thank you very much.
So thank you very much for the 2 questions. I will start by responding to the question that talk about how can the 2 interventions be leveraged open. So as I mentioned in the presentation, most of the global findings are accidentally found. So all these things are done with no intention of being studied, but they are findings that the Kano model is coming from the government official, specifically is the current executive secretary of the Primary Healthcare Agency of Sokoto, who is from Tambuwal, that stood, if it can happen anywhere, not in my own local government. So she started the mobilization of the senior officials from the LGA. So, and then eventually we have seen the result. So there was no intention of saying, okay, let's see whether it will work or not. So it's not formally studied. So then this one is the villagers themselves, with nobody coming to them who is educated to say, let's do this thing to salvage our problem. So this is one coming from the government, one coming from the private sector entirely. So what I think as Nigeria we can do is to look at these 2 models, put a theory of change on them, look at any model that is used for behavioral change, and see, okay, how do we penetrate communities to develop Tunga model that we push them on the ground, that to understand the impact and the magnitude of inability for us to control immunization coverage and continuously having 0 dose, so that they will be the agent of change themselves. So once this we're able to put theory on them, develop a framework of how to implement the theory-based intervention to the latter, I'm sure we will be able to see a significant change in reduction of the 0 dose. So the same thing applied to the temporal model, because if you just say, oh, all societies go and develop a temporal model, it will be haphazard. But apply proceed model, or health belief model, or social cognitive model to it, so that social behavioral change expert can look at the model, study it, and then look at which model is most suitable, and then develop a document of how to guide the communities to develop this. I'm sure when we do this, we will be able to see some changes. And for the question number 2, why are impactable interventions, which is clear, when you bring them in Nigeria, you see minimal impact compared to where it is done? So here is because, one, I saw one of the presentation was talking about the attitude of healthcare workers. I stumbled on a presentation that was looking at one of the why we have immunization defaulters is because of the poor attitude of the caregivers. One, sometimes you're supposed to explain about the side effects. Some caregivers will be careless to do that. The poor mother, uneducated, get the side effect, she will not think twice. She will not come back. So, but and then there is no accountability. If this guy, we find out somebody did not come back because of the side effect, and the appropriate thing to do, which is to explain the possible side effect, is not done, that person should be held accountable. So we don't do that. Worst being worst, we don't have policies that guide what we do. Ideally, whatever you do, you should have SOP on how to do it, so that if 1 million people are to do the same thing, they will do it the same way. Most of what we do here, we don't develop SOPs on how to do things. If there are SOPs, they are just for documentation. We don't follow them. We don't ensure that the people that are supposed to use the SOPs are using them. So if we are able to change that, believe me, if we bring any intervention that works in Sudan, when you bring it to Sokoto and follow it religiously, it will work. But we want to do things in our own way. Definitely, we see the result that is different from where it is done rightly. So as I mentioned in my presentation, we need to look at the governance issue, looking at the documentation, implementation of that document that we develop, whether it's policy or strategy or whatever you call it. You should have a plan on how to implement it. And that plan on its own should be backed by proper accountability measures on what to be done to someone that's supposed to do X and he refused to do it. What will be done to a person that, and also the reward component, so that the person that do the best of what he should be rewarded either by certificate, promotion, or whatever we do. So once we do that, we do these things, documentation, implementation plan of the document, accountability, reward and sanction of those things, I'm sure we see difference. And also placing our interventions based on theories. It is documented that interventions that are theory-based produce more result and more impact than interventions that are baseless of any theory. So this, when we do that, when we do all these things, I'm sure we'll see a significant improvement in the impact of our interventions. Thank you. I hope I answered the questions.
Thank you, Dr. Hamed. Haji Rama, to respond to your questions, please, I'd request you to be brief. We'd like to take some experiences from the participants as well. Thank you.
Thank you, Margaret. So I think we had some questions around the need to delineate the ward into enumeration areas. So we actually did this because, please, am I audible? All right, so there was a question around the need to delineate the word into enumeration areas. So we actually did this because, you know, over time, using the list of settlements, sometimes during surveys or enumeration like this, some new settlements tend to be missed. So we did that to ensure a very good coverage. And with that, we're able to cover every aspect, every area in the world, except where we had security challenges. And that also helped with the rationalization of workload for the teams that we recruited. So moving to the second question around card retention and how we're able to ascertain the vaccination status of children, you know, especially those children who are above, you know, the 2 years of age. So just to mention that during that data, that question actually coincided with the data that we gathered from the field. You'll notice that for children below 2 years, the card retention was actually higher. So just to answer this question straight or directly, what we did was during the training, having known this kind of factors, you know, could come up during the training, we also trained the team on the immunization, the child health card. So we trained them on the child health card, how to get information from child health card. So in the event where the child health card is missing, we also train them on how to use caregivers recall. So what we used for that was caregivers recall. So, and we also trained the teams very well on how to ascertain that, the sites of the vaccination, and all that helped to use the caregivers recall to ascertain the immunization status of children whose immunization cards were missed. Thank you, and thank you for the questions too.
Thank you for those brief submissions, Hajia Ramatu. Moving on to some of our attendees here that have their hands raised. I have Fatima El Yaqub. If you can hear me, please unmute yourself and share your contributions. Fatima El Yaqub. Fatima El Yaqub. Jamila Buhari, you had an experience to share with us. Is that Fatima? Yes, Fatima, go ahead, please. And after you would be Jamila Buhari. Fatima, go ahead if you can hear me, please.
My name is Fatima. Okay, thank you, ma. I just want to share some of my experiences with regards to zero dose and the use of DHIS2 and RSMS to track actually data data conducted on sessions. On sessions conducted in the facilities and the LG at large. So what I want to say is the use of SMS. I think the use of technology, especially the SMS platform, has actually improved our data reporting for the LGA and the facilities. So what we actually do now is that when sessions are being conducted, we get to see data sent immediately for sessions for that day. So when we have sessions conducted, whether fixed or average session conducted, where children are being vaccinated and tracked, data can be seen on the SMS platform the next day. So whatever information we have, we actually see the number of children vaccinated, vaccine doses used, and we know how many sessions, even the data are going to be summed, analyzed, and uploaded into the DHIS2 platform. So I think the use of technology in tracking of children vaccinated, the use of DHIS2 platform has actually helped increase has helped us to see data being generated during sessions before end of month. And if there's any activity for us or any action for us that needs to be taken, can be done before the end of the month. So can you hear me? Hello? Okay.
So it's a bit choppy, we can hear you.
All right. Okay. I want to also talk about actions being taken by LGA team and the partners with regards to the SMS. And also because of the data being analyzed on a weekly basis, sometimes on a daily basis by the LGA team and partners, we tend to see activities, if actually children are being vaccinated or not, how many children being vaccinated, if we actually need to improve on activities being conducted in the LGA facility. So I think use of this DHIS2 and use of this RSMS has been presented by Mrs. Ramatu has actually improved us in tracking number of children being vaccinated at the end of the day and at the end of the month also. And so children being vaccinated at the end of the month analyzed, and children being vaccinated on the DHIS2 platform and on the SMS will help us analyze data and see whether our target for these zero dose are being documented or not. And our target for this zero dose children are being reached. And the documentation for those data are being available at the LGA facility and even the national, actually trying to see the number of outreaches being conducted, the number of children being conducted, sessions being conducted, and the number of children being tracked and vaccinated. Both zero dose and the under-immunized children in the LGS have actually improved our data quality, I think, at the end of the day. Thank you. Hello?
Thank you very much, Fatima. Yes, thank you for your contributions. Thank you for letting us know how DHIS2 has impacted work in your area of expertise, especially with zero dose children. Jamila Buhari, please, your experience. Don't see her online anymore. All right, moving on to Abdul Rashid Bello Aliyu. Abdul Rashid Bello Aliyu. We'll soon be rounding up our discussion session. Please go ahead, Abdul Rashid Bello Aliyu. Sufiyanu Umar Mohammed. It's Safiyanu, sorry. Safiyanu Umar Mohammed, your contribution, please. Safiyanu, can you hear me? Mubarak Ilya. Mubarak Ilya. Mubarak Ilya.
Hello, can you hear me?
Loud and clear, sir. Please go ahead.
Yeah. Good evening. My name is Mubarak M. Ilya. I'm the NSLO Dambata Makoda, Kano Cluster, Kano State, Nigeria. I want to share my experience from Dambata LGA, Kano State. Dambata LGA is one of the 15 zero-dose LGAs in the state, and we have 10 political wards in the LGA. Dambata LGA is classified as zero-dose because there are some settlements that are RI non-compliance due to religious belief. The experience I have for Dambata LGA of Kano State is there is non-compliance due to religious belief in some of the settlements, where I have an engagement with members of the settlement, and the settlement is called Sankarawa Settlement of Dambata West. I took ample time to explain to them the implications of zero-dose children in the community. I also reiterated the importance of religious stakeholders as members of the community, stating clearly their roles and responsibility in relation to zero dose. This yielded a remarkable improvement in reaching some of the zero dose children in the settlement. So I ran a small analysis where the Penta-1 coverage of one of the health facility of the catchment area of Sankarawa settlement rose to 11%, where the dropout rate dropped to 3%. So finally, my next step is to scale up this strategy in one of the wards that also has some pockets of RI non-compliance, so as to reach the zero dose there and some of the defaulters. This is my experience from Dambata LG of Kano State. Thank you and over.
Thank you so much for sharing your experience, Mubarak Ilya. That was very insightful. Moving on, we take the last but not the least contribution from Bilkisu Abdullahi. Bilkisu Abdullahi. Please unmute yourself and share your contribution. Bilkisu. Mele Malam Ghana. Mele Malam Ghana, if you're still online, please unmute yourself and ask your question or make your contribution. It seems we have hands raised, but no questioners at the back. I'd like to ask a question very quickly. There's a question in the Q&A box that says, it's obvious that PPPs are contributing a lot, that should be public-private partnerships, are contributing a lot towards immunization coverage improvements in Nigeria. Strategies have to be taken for sustainability to ensure that our communities accept the intervention by choice and not by chance. That's what Habibu Abubakar Yaro contributed. For those of you asking for the webinar resources, I'd like to quickly remind you, we are dropping some links in the chat boxes that are resources to all the webinar editions that I've held so far. So please feel free, click and download from the chat box at will. I will take one more question for today. It's a question that has been answered in the chat box by Jamila Buhari. She said, my question goes to Mr. Adams. What strategy does AFNet and AHBN have to support the LGAs in knowing the actual number of zero-dose communities in our LGAs for easy tracking and smooth implementation of the exercise? Because we don't have the actual data here in our LGAs. Adam, you could respond to that very quickly and end the discussion session with that. Thank you.
So thank you, Margaret. I think that's a very good question that has been bothering most of the LGEs. Currently in Nigeria, the last census was conducted in 2006, and since then we've not had an updated community-based enumeration that we can really say that this is the actual number of this particular population in country. However, there have been some estimations done by the National Primary Healthcare Development Agency, especially around routine immunization, looking at under 1 and under 2 children. They've also been other interventions such as the IEV that was implemented where under 15 were actually enumerated in some parts of the country. However, this is not something that is generalized across the country. They are being done in isolation. There is a current project that is ongoing, which is the Saman project, where some enumeration are actually being implemented. And I think Kano is one of the states that are currently benefiting from such intervention. I believe that collaborating with that project, both at the LG and at the state level, will really provide some useful information that you can actually use in getting the actual number of the under 1 and under 2, as well as the other population that you might need for your programming. I think if I'm correct, the implementation commenced today for the enumeration. I think working with the LGA team and the partners involved in that will really go a long way in getting that information. But at the national level, we only use estimates, and some of those estimates, as what we have on DHIS2, some of them have shown to be either overestimated, while some have been shown to actually underestimate. This is something that is a big issue currently in Nigeria, and since we have no other data source, it's something that we've been managing. But that, I think, will give you more useful information than what we currently have. I hope I answered the question. Thank you, and over.
Thank you very much, Adam, and thank you to all our presenters for today. Thank you to all participants as well for your questions and valuable contributions. They have greatly enriched our discussion. To close this discussion session, I'd like to invite Dr. Endi Waziri, the Affinate Immunization Advisor, to provide the final insights. I'm inviting her as the icing on the cake. She will share her expertise in immunization, tying together the key aspects that we touched upon today: engagement of the private sector, technology, and decentralized immunization monitoring. Over to you, Dr. Endi Waziri, for your final insights on the discussions. Dr. Waziri, can you hear me?
Okay. Yes, can you hear me, Margaret?
Loud and clear, ma. Please go ahead.
Okay, so good evening and good evening, colleagues. Apologies for the earlier hitches that we had. My internet suddenly went off in the office. So instead of an opening remarks, I think I'll just share some very quick insights. So we've heard from 3 experts. We've heard 3 innovative ways of reaching zero-dose children through the decentralized immunization data monitoring, use of information technology to improve uptake of vaccination, and also the impact of public-private partnership to improve uptake of immunization. We've had key examples, and I've had some of our staff give their insights from where they work. So always insights from the field, the importance cannot be underestimated. I think we need to sit together, go back to the drawing table, and look at how can we harness these 3 innovative strategies. How can we put them together, bring them to work, and reach every child that is not reached, wherever the child is. It doesn't matter. So when we talk about equitable vaccine access, it means that wherever the child is, the child should have access to vaccination services. And one key thing that has come up, though not mentioned here, is the issue around fake finger marking. I heard that there are studies now going on to find out why this is ongoing, because it marks what we see on the field. So if you go and you have a child that is already finger marked I'm not sure if it has advanced to giving fake cards, but everything is possible. So we need to do additional work to ensure that every child is reached. How can we leverage this information technology at a wider scale beyond what Ramatu presented? How can we scale up the decentralized immunization monitoring, engage communities, involve them in all the strategies? Because at the end of the day, everything that we do is all about the community. It's all about reaching the unreached communities. So how can we get them involved? And then in terms of public-private partnership, we heard of examples like the M-Pesa. Are there people that can come up with those kind of innovative strategies amongst us so that we can try it, pilot it, and then look at successes, learn from the mistakes, take corrective measures, and then scale up for vaccination in. So Margaret, thanks so much. This has been an exciting session from the decentralized immunization monitoring directly for the first time. So thanks to all the presenters, and over to
you. Thank you so much for your excellent presentation, Dr. Waziri, and for balancing it all so gracefully. It's inspiring to see your dedication not only to your work, but also to your family. We truly appreciate your efforts. And with that, we've come to the grand close of our 5th edition of the Zero Dose Learning Hub Nigeria webinar series. Thank you for all the engaging discussions and your participations. Before we close, I'd like to call upon Dr. Helshilni Waziri, the technical lead for capacity building and research at the Zero Dose Learning Hub Nigeria project at AFNET, to deliver the closing remarks and the vote of thanks. Dr. Helshilni Waziri, over to you, sir.
Thank you very much, Margaret. Good morning, good afternoon, good evening, depending on where you're joining from. So on behalf of AFNET AHBN Consortium, supported by Gavi, the Vaccine Alliance, I wish to extend our sincere gratitude to everyone who has made this webinar a success. I'd like to thank our esteemed speakers who brought depth and expertise to today's discussions. Your insights on leveraging technology, empowering local stakeholders, and fostering strategic partnership have been both enlightening and inspiring. It is through these contributions that we can chart a clear path towards bridging the immunization gap and ensuring no child is left behind in terms of immunization. I'll also want to recognize and appreciate Gavi for its unwavering support and commitment to strengthening immunization systems globally. The support to Zero Dose Learning Hub and Nigeria as a whole has been pivotal in advancing projects that ensure every child, no matter where they live, has access to life-saving vaccines. So our moderator, thank you for steering these discussions so effectively, ensuring a seamless flow of ideas and encouraging active engagement from our audience. Your support has enriched today's dialogue and created a platform for meaningful exchanges. To our participants across various sectors around the world, from government agencies to non-governmental organizations, academia, and also the private sector, your active engagements have been valuable alongside the contributions throughout this webinar. Special thanks to AHBN for their support. And lastly, thanks to all colleagues at AFNET for planning and coordinating this webinar. Organizing this such webinars is no small feat, and dedication to promoting health equity is commendable. As we conclude today's discussion, let us remember that The fight to close immunization gap requires sustained efforts, innovative thinking, and above all, collaboration. Together, we can ensure that no child is left behind, not just in terms of immunization, but also having equitable access to healthcare in pursuit for healthier individuals, especially in Africa. Please join us again for the 6th edition of the webinar series, which promises to be exciting and engaging as usual early in 2025. Thank you very much. Enjoy the rest of your day and see you next year.
Thank you very much, Dr. Elshilni Waziri, for your closing remarks. Before we end the session for today, a quick poll will be popping up on your screens. Kindly take a moment to give us feedback on this 5th edition of the Zero Dose Learning Hub Nigeria webinar series. Kindly note, there was something we noted during the webinar that some participants registered or shared their links with their colleagues. And so we had multiple registrations or multiple attendees with the same names. We'd like you to know that such participants may not receive the 5 CME points or the certificate of participation. So we kindly discourage this practice. It may inadvertently affect the eligibility of other attendees to receive their CME points or certificates. So when we send out the webinar invites, try and register on time and save the invitation on your calendar so you have a notification right before the webinar starts. That way you would have your own registration, your own CME points, and your certificate. Thank you for your engaging discussions and thoughtful contributions, everyone. On behalf of the Zero Dose Learning Hub Nigeria team, we thank all our speakers and participants for making today's webinar and the entire series this year a great success. By the way, this is the last webinar for the year 2024. Your dedication to tackling zero-dose challenges and improving immunization coverage is truly inspiring. As we conclude this year's webinars, we wish you a joyful holiday season and a fulfilling end to 2024. We look forward to reconnecting with you in 2025 with fresh insights, renewed energy, and stronger collaborations. Thank you again for your commitment and have a wonderful day. Bye.